Thank you, Reese. Hello, everyone, and welcome. As Reese has already welcomed you, I'm Maxine Linda Glautenberg. I'm co-coordinator of the Saratoga Immigration Coalition. And on behalf of the Saratoga Immigration Coalition, Temple Sinai, MLK Saratoga, the Saratoga Healthcare Committee, LifeWorks, formerly known as EOC, and Caffe Lena, we welcome all of you here tonight and are really appreciative that you've taken the time this evening to come and learn about healthcare justice. And as Dr. Jolly, our presenter, pointed out to me earlier in the week, that it's really a night about rethinking how we finance healthcare and how that financing can really bring greater justice to everyone across the board. So just a little fun fact, or not such a fun fact, 55% of uninsured New York residents are people of color, uninsured Asians, Hispanic, and Black people, and are more likely to be immigrants. Hispanic and Native American children are twice as likely as white children to be uninsured. So tonight, we're going to be exploring these healthcare injustices. And in addition to highlighting these disparities, Dr. Jolly is going to speak to us about the New York Health Act, just recently renumbered this week, A 6058 and S 5474. And he's going to give us insights as to how this act could bring greater healthcare justice to New York State. As Reese said, we encourage you to ask questions. The chat will be open all night, and Reese and I will be working together to make sure that at the end of the program, Dr. Jolly will be answering those questions. And just a little bit about Dr. Jolly. He was a practicing physician in Saratoga Springs for 36 years, doing internal medicine and geriatrics. And while he primarily saw people in his private office, he also worked at Saratoga Hospital as an emergency room doctor, an attending physician, and he was chair of the Infection Control Committee. He also was a director and clinician at 2 nursing homes. And all of these experiences drove his interest in healthcare finance and the need for reforms to right inequalities therein. He is a member of the Saratoga Healthcare Committee and has been a longtime member of the Physicians for National Health Program, or PNHP. And I also know that Dr. Jolly is a musician and has been known in the spring to make a pint or two of maple syrup, and he is an excellent baker of bread. So with that, I'm going to turn it over to Dr. Jolly. And again, make sure you put your questions in the chat, and I'll also see you on the other side.
Maxine, thank you very much. I want to certainly thank Caffe Lena, Saratoga Immigration Coalition, Temple Sinai, LifeWorks, the Saratoga Health Committee for sponsoring and participating in this Caffe Lena classroom event. It's our job tonight to imagine what will be required to bring justice to the healthcare system. I'm going to encourage the advocacy groups represented here to be aware of the New York Health Act, which is being introduced in the New York legislature this month. The act drastically changes the way healthcare will be paid for in New York State. And we're going to address the sort of issues of why the finance is so central to healthcare justice. I'm going to begin by presenting a few of the health issues that are faced by some of the groups that are important to the sponsors here at this program. I'm going to share my screen. going to get out of the way. These factors are shared by all the groups that we have just mentioned. People of color, immigrants, and people living in poverty. I'm only going to mention a few issues for each group, and there are always additional other issues that we could discuss. But we'll see that several themes are shared among the three groups. And here some of them are. In this country, most healthcare is financed through insurance. Many people in these three groups lack adequate health insurance. Even when insured, many households have limited financial resources, like limited savings and a limited income with which to manage out-of-pocket expenses associated with health issues. These groups often share a distrust of government and authority, which makes it more difficult for them to engage with the healthcare system. I want to suggest that there exists a neighborhood effect. Where you live matters. The environment that people live in exposes individuals to can expose individuals to unhealthy conditions, inadequate public resources, and to stress. Of course, changing the ways we access and provide healthcare alone won't correct those the last two issues. These communities have reasons known to many of you for not trusting government. Building trust is a lengthy process. Neither will improving healthcare alter the living conditions of disadvantaged communities. However, healthcare justice can increase resiliency and reduce some of the barriers that now prevent many from achieving their potential. Let's look at racial health inequities. Maxine referred to some of this. People of color account for half of America's uninsured. Hispanic and Black rates of uninsurance are significantly higher than the average. Insured Black families spend 20% of household income on premiums. That compares with only 7% in median income households nationally. Many of the plans purchased by this community are low value, high deductible plans. For example, the bronze plan that's available on state exchanges, the bronze plans, were designed to cover only 40% of expected medical costs. The relatively low initial cost may feel like a bargain, but until coverage is really needed to deal with a major illness or hospitalization. Nearly a third of Black Americans aged 18 to 64 hold past due medical bills. Majority Black communities are much more likely to have a shortage of primary care doctors and are more likely to see the hospitals in their communities close. Racism is a factor at all levels of income. It increases stress and reduces opportunities for social and economic advancement, which might ameliorate health disparities. 31% of non-whites face medication insecurity, that is inadequate resources to pay for needed medication in any 12-month period. That's compared to 20% in whites. Racial healthcare disparities result in disparities of health itself. Among today's 40-year-olds, Blacks will live 6 years fewer than whites. Compared to white Americans, Blacks are twice as likely to die from diabetes, 7 times more likely to die from HIV/AIDS. Black women are 71% more likely to die from cervical cancer. Blacks in general have about 22% more deaths from heart disease. Black mothers are twice as likely than white mothers to lack prenatal care, and 320% more likely to die from pregnancy-related complications. Black babies are twice as likely to die in infancy than are white babies. Most of these deaths are preventable. Let's think a little bit about immigrant issues. There are about 45 million foreign-born individuals living in the United States today. That's the most ever. In New York State, it amounts to about 4.4 million. A little over half of those individuals, folks, are naturalized citizens. Of the remainder, about 2/3 are legal residents with green cards. The rest, about 700,000 in New York State, are considered undocumented. Health data about the undocumented is understandably hard to obtain. Both lawful and undocumented immigrants are likely to delay seeking medical care. Language difficulties make negotiation of health care. Language difficulties make healthcare more stressful and less effective. About a quarter of foreign-born New Yorkers have significantly limited English. Distrust of government and fear of deportation is a major issue in immigrant households throughout the country. Undocumented immigrants are ineligible for Medicaid or marketplace coverage. Currently, 23% of lawfully present immigrants do not have any health insurance at all, and 45% of undocumented immigrants lack any health insurance at all. Immigrants are very likely to lack primary care. Ironically, the health care industry is the largest employer of immigrants. They're not taken care of very well, however. I want to cite here some of the health inequities in poverty. Low income is strongly associated with illness and death. People of low income have shorter life expectancies, and low income adults are more likely to report ill health. Health problems reduce income, and low income reduces access to care. That creates a negative feedback loop that sometimes is referred to as the ill health poverty trap. Income and wealth equality are worsening in this country, further exacerbating health disparities. Medicaid, our major safety net program, often discourages increased financial independence through its means testing. Reporting additional income can risk losing coverage. The inequities in the healthcare system create barriers to a good health for the poor. The poor are less likely to work jobs, are more likely to work jobs with lower wages and without health insurance benefits. The poor have higher rates of risk factors for poor health, like smoking and obesity, substance use, and low levels of physical activity. The high poverty neighborhoods have less access to fresh food. And at the same time have higher availability of unhealthy fast foods. And those neighborhood environments are not conducive to physical activity. High poverty neighborhoods expose residents to increased chronic stress, including toxins, deteriorating housing stock, under-resourced schools, higher rates of unemployment, and higher rates of incarceration and violence. Political structures perpetuate poverty, favoring the interests of the affluent and well-connected. Political structures thus have health implications. Oops, sorry, so I should have been there. So COVID has made everything worse. In the early months of 2021, COVID became the leading cause of death in the United States. Residents with low income, recent immigration, whether documented or not, and people of color are more likely to be exposed to the virus because they live in crowded, multi-generational households. They work in what are called essential jobs in direct contact with the public. They depend on public transportation. Tragically, these folks are more likely to die if infected. Black and Latinx make up about 31% of the population, but are responsible for 50% of the COVID deaths. Many workers who were insured lost their insurance when their employment ended in the epidemic. Okay. Let me go back and review those factors held in common. Lack of inadequate health insurance is associated with excess financial stress, illness, and death. Safety nets like Medicaid are not sufficient as doctors and hospitals serving that population are not adequately paid. These families have limited resources with which to manage health issues, all the way from well baby care to life-threatening disease. There's a neighborhood effect. Community living conditions expose individuals to unhealthy conditions and inadequate public resources and to stress. Distrust in government follows years of discriminatory policies. We have structured health care and health insurance through which it is largely accessed in this country in such a way that it increases stress and reduces access for some of our most disadvantaged groups and most disadvantaged residents. Simply said, it's not fair. Let's look at what principles healthcare finance could be built on. The value of people, all people are created equal. That's the oft-quoted principle. As I read it, all people have equal value. That statement might sound straightforward, but as in our history, it has been very complicated. American culture has been evolving out of mostly European perspective that viewed people of color, women, indigenous people, in fact, any foreigner, as of lesser value. We are still arguing over when an unborn fetus attains enough value for it to warrant its protection under law. I mentioned that almost impossible thorny controversy to remind us how difficult the edges of this discussion can be, since different people see defining lines at different spots. However, I'll still propose that the best healthcare system would try to regard and respond to everyone equally. While I claim that we are all of equal value, I also recognize that each person's need for medical care is determined by their health circumstances. I'll call that medical necessity. In the issue of medical necessity, however, we're all created unequal. Medical needs are individual. I want to say a thoughtful consideration of the needs of others is an essential way we demonstrate our appreciation of their value. Commitment to basing care on every person's medical needs rules out the use of other criteria, such as the ability to pay, or immigration status, or racial or ethnic origin. I have to point out that not everyone agrees that medical necessity should determine access to medical care. Some want each individual responsible for his or her care and consider that something they call skin in the game is a good marker of taking responsibility. Unfortunately, much illness occurs at random in the population that does not take into account a person's capacity to take responsibility. It also happens that many illnesses have other determinants, which have little to do with the efforts of the individual to be responsible. I believe that taking responsibility is actually a code word used to monetize healthcare. Monetizing, that is putting a price on everything, is probably okay for access to cars and televisions, but there are some unacceptable consequences when it's applied to healthcare. Instead, we need to accept and share the social responsibility to provide health care to those who need it. We do that with public services like firefighting. For me, fairness dictates that sick people should not have to deal with the additional stress of trying to find money to pay for a care that has been deemed essential. As I pointed out, there are idealistic reasons for structuring healthcare to make it healthcare finance to make care equally available to all, based on the equal value of each person. But can we insist that everybody participate? Compulsory participation is something that is hard for Americans at all levels of wealth. Death and taxes come to mind as things we can't get out of. However, there are some systems with rules for that everyone is expected to follow. Traffic laws, for example. Those rules don't require us to drive, but when we do, we know that for our own good and for the general good, it's best that the rules apply equally to all of us. A practical benefit of universal participation is that each person, regardless of wealth, will commit to the success of our healthcare system. In such a system's success will structurally depend on the self-interest of each person. Our government leaders will have that have the same access to health care as the lowest paid resident will make sure that access is available to everyone. Our present system structures access on the ability to pay. We know that wealth varies greatly, so there should be no surprise that multiple levels of access and quality have emerged in our system. American healthcare is delivered by a plethora of providers and doctors and their extenders and hospitals and clinics. Americans seem to like it that way. In matters of personal health, we want to deal with people with whom we feel compatible. Our healthcare system tries to apply the notion of extensive choice to healthcare finance as well. The insurance industry likes to claim that Americans love their extensive choice of insurance plans. Currently, the US has 900 companies offering health insurance coverage. Of course, each company has multiple plans with different rules, benefits, and prices. That complexity is consuming 25 to 30% of every healthcare dollar spent in the United States. Complexity has to be negotiated at every level of the healthcare system, provider offices, hospitals, pharmacies, and of course by each of us. Has anyone recently looked at a health insurance document listing what was charged, what was covered, and what you were personally responsible for? The report makes no sense at all. For every single healthcare service you might receive, billing clerks in your physician's office or hospital have to determine which plan you have, supply the documentation required for that particular plan to justify the service. When the insurance company receives the claim, again, administrative workers will question the need for the service. How much is actually paid to a provider varies wildly. About 10% of claims are rejected and have to be resubmitted. That complexity costs a huge amount of money, both for providers and for the insurers. Well, do we really need insurance? We use insurance of all kinds to deal with economic uncertainty. Health insurance fills that function because no individual can know the course of their health journey. As complexity and cost of medical treatment is increased, the consequences of being uninsured have become overwhelming. Most of the 500,000 Americans who filed for personal bankruptcy in this last year filed due to medical bills. It's especially sobering to know that most of those who filed were actually covered by insurance at the onset of their illness. The Association of Employment and Health insurance is an historical quirk. Employers added it as a competitive benefit to attract workers in World War II. That association, from the point of the worker, is somewhat illogical, since getting sick commonly prevents people from working with loss of insurance, even when it's most needed. Employment-associated health insurance also proves unreliable if somebody wants to change jobs, if somebody wants to start a new business, or if somebody loses their job in a period of economic downturn or during an epidemic. The insurance industry has, however, flourished, as anyone familiar with the stock market knows. Promising better service, commercial insurance has taken over most of Medicaid in New York State and large portions of Medicare. The complex structures of the insurance industry have brought with them additional expense, diverting resources away from actual health care. Profit to a commercial insurance company is a lesser but not trivial cause of unnecessary expense. It bothers me that insurance companies skim the funds off premium revenue to pay for investor profits and to pay exorbitant CEO salaries. Finally, insurance company is a business. It does have a bottom line. Paying for patient care is a loss. Insurance companies mark their success by minimizing patient care. That strikes me as a clear conflict of interest. Discrimination against people with small financial resources is built into our finance of healthcare. Collectively, we spend about $10,000 annually for the healthcare of each person in New York State, but 30% of that is going to administration, leaving the resources for actual care greatly reduced. U.S. insurance companies adjust their prices to cover their expenses. Like any business, those expenses are actual medical care, and in addition, administration, paperwork, which involves paperwork on claims, executive salaries, profits, and advertising. Those costs, which have been rising for faster than inflation, are mostly paid by employers as employee benefits, and by employers and by government entities through programs like Medicare Advantage and as employee benefits for public employees. Individuals who get their health insurance at work buy it on an exchange or enroll in a plan like Medicare Advantage, pay in addition out-of-pockets, co-pays, and deductibles. Provider reimbursement is skimped on in public programs like Medicaid. That makes Medicaid a particularly good target for insurance companies, since the cost of care has been curtailed, historically curtailed. Some people, currently about 1 million in New York, just simply go without insurance. These financial structures have health consequences. People delay and omit needed care because of expense. Who does this harm fall on? It falls upon especially on marginalized, disadvantaged, and these overlapping groups in our society, people of color, the poor, and immigrants. There are other ways to organize healthcare finance. Our Canadian neighbors use provincial public insurance and achieve a per capita cost just a little over half of what we spend per person. They see better health outcomes than we do as well. Some European nations with strong traditions of social cohesion manage to maintain healthcare access for everyone better than we do by using highly regulated insurance companies. That strategy gives fairly good healthcare outcome statistics, but it also costs more. Even when we install the most efficient possible healthcare finance, healthcare will still be expensive. So here's an obvious question. Who will pay for a very expensive public good that all of us will use? When we want to build an interstate highway system or a battleship, we ask the government to finance it. We pay for those investments through progressive taxes, asking people with more resources to contribute more. I think progressive taxation is fair, but I recognize that some people will disagree with that. To summarize, I want a healthcare system which will value all people equally. Fair access to care is based upon medical necessity, not on the ability to pay. The healthcare system will enroll all residents and all licensed providers. Alternative insurance in the state should not be permitted for covered healthcare services. And a just system will be financed through progressive taxes. Please consider with me the difference between health and healthcare. We make that distinction is really important because we can each, the optimum health we can achieve depends not only on the healthcare we receive, the doctor we see, or the hospital we go to, or the medicines we take, but also on a range of factors, the determinants of health. They are the kind of work we do, where we live, our wealth, our education. As an individual, health also depends on your personal genetic makeup. However, human beings as groups, despite differences in appearance, are much more alike than they are different. We need to be very careful about attributing health outcomes to built-in differences between groups. Most differences in health outcomes between groups are due to differences in environment and cultural factors. Making the distinction between health and healthcare is important because it reminds us that even a just healthcare system won't by itself eliminate all health disparities. It is, however, a big step in the right direction. Will healthcare justice really make a difference? In fact, universal, comprehensive coverage is proven to reduce health disparities. The two examples I want you to be aware of, one is the veterans health system, where Black men are 37% less likely than white to develop heart disease and have a 24% lower death rate. That's a significant improvement compared to the general population. In our country, patients with end-stage kidney disease and dialysis qualify for Medicare coverage. Once on Medicare, Black patients with kidney disease survive longer than whites. Equalizing access makes a huge difference. Now, I and many others have been fussing with the principles of what will be and strategies that will be required to make a truly fair healthcare system. And what I presented here tonight reflects a lot of the positions of the Physicians for the National Health Program, PNHP, which I've been associated with over the last more than 20 years. Most of us would like to see a national single payer system, universal healthcare system, like Medicare for all. And while progress has been made on the national scene, it appears that the government in Washington is not going to move in that direction anytime soon, in spite of the excellent Medicare for all legislation recently introduced in Congress. As a result of that situation, many of us have focused on state plans, and this brings us to the New York Health Act, which is at an absolute critical moment being introduced to the state legislature this month. The New York Health Act creates a legislation that would, is a single public health insurance covering all New York residents, regardless of immigration status or employment status. It was passed by the Assembly each of the last 4 years and is being introduced for the first time in a newly Democrat-controlled New York Senate. It will cover all necessary medical care. And that's the thing we've got to go back to repeat it. When you ask, well, how will it measure up to my present plan? This plan, the new plan, will cover all necessary medical care. How do you determine if it's necessary? If a licensed health provider says it's necessary, then it's necessary. It will also cover vision, dental, and long-term care with no additional copays, no deductibles, or additional premiums. It allows free choice of provider, doctor, and hospital. The act is financed through progressive taxes on both earned, that is payroll, and unearned income. And unearned income would be things like interest, dividends, and capital gains. The act eliminates all other public insurance. Medicare and Medicaid would be folded into the New York plan. It eliminates private insurance for services that are covered by the New York plan. Immense savings accrue due to administrative simplicity throughout the system. The act requires New York Health to negotiate drug and medical device prices. Combined, those savings will allow us to cover all New York residents while reducing overall cost. To many of us who have insurance now, the Health Act under New York, the healthcare under New York Health won't feel much different. However, over 90% of New Yorkers will see reduced overall healthcare expense. 90% will see reduced healthcare expense. For the groups of people we've been discussing here this evening, it will be transformational. Let's just conclude before we go on to questions by reviewing how the New York Health Act will promote healthcare justice. The New York Health Act values all people equally. The governor and the fast food worker will have the same health insurance. Medical necessity controls care. There are no out-of-pocket expenses. Third, the New York Health Act will enroll all residents and all licensed providers. And fourth, the alternative insurance will not be permitted for covered healthcare services. Finally, the New York Health Act will be financed through progressive taxes. If what I've presented here makes sense to you, and you believe that a program like the New York Health Act will benefit all New Yorkers, including the marginalized groups you're concerned about, now's the time to contact your state legislators to voice your support. If you'd like additional information about the New York Health Act, I encourage you to look up the Campaign for New York Health at newyorkhealth.org, nyhealth.org. The campaign website also has links to help make contact with your state legislators. And I am going to return now to Maxine, and we can proceed with questions. There she is.
Hi, Terry. Thank you. Thank you very much. So, as you were talking and even before, I had some questions that came to mind before we get to other people's questions. Um, and you kind of covered this, but something that's come up for me has been like the complication, like how complicated it would be to switch from um, the system that we know now to just that single system run by the state. And then kind of morphed into that too is what would happen with all of the jobs that are now provided by insurance companies. So,
Okay, the horrible complexity of our healthcare today is the reason that we need to change to a simple system. And I want to point out that for our healthcare providers, doctor's offices, for example, we're used to having new insurance. There's a new insurance plan, new company on the market every multiple plans every year. So picking up a new plan is nothing, but it'll be dramatically different not having to deal with all the other 900 plans. Having one plan will be so much simpler. Historically, Medicare was the whole Medicare system, which is the most popular health system that was ever health legislation ever passed in this country, was rolled out in less than a year in 1965 when there was no internet and no email to communicate with everybody. It was all done with snail mail. And I don't have any problem at all thinking that we'll deal with that complexity. So I think that the issue of complexity does reflect how wildly complex our system is now. I mean, the scare tactic of referring to complexity is just that, a scare tactic. It's going to be a great big puff of smoke when the air clears. It's going to seem so natural and sensible. There are thousands of workers in this system. Thousands. I mean, I think the number is a couple 100,000. And the New York Health Act is actually built into the legislation 2 years of income support and of retraining for those people, because many of those individuals have healthcare training and could serve in other parts of our healthcare system and still be healthcare workers, but not pushing paper the way they are now. So that's built into the New York Health Act. I think those were your two.
Yes, those were. So next question, how will medical personnel get paid through the Healthcare Act? And I would tag on to that, just because of reading I've been doing, how will those payments compare, like the payments for their services compare to the payments they receive now?
Okay, the last thing first. The level of payment under the New York Health Act is being targeted at slightly above Medicare rates. In this country, there are three levels, tiers of payment for healthcare services. Same service, completely same service, same appendix, same three different people. If depending on what your insurance is, the doctor gets three different prices. Medicaid is the lowest. And it's been inadequate to keep practices going. Medicare is an intermediate, and as a geriatrician, I have lots of experience with that, and it's satisfactory. Commercial insurance pays on the average a little higher than that. So that the the Medicare rates that a little above the Medicare rates have been targeted as the level of care. The results of that for the income of providers depends on what your income, what your specialty is. Certain surgical specialties that are the highest paid now will see a drop in income. Some specialties will see a rise in income. Particularly primary care docs and mental health workers. Hospitals are another fascinating thing that hospitals, the income for hospitals is determined by what their patient mix is. If they take care of mostly commercial insurance, they get paid pretty well. The New York Manhattan hospitals are examples of that. If you take care of primarily Medicaid patients, indigent non-paying patients, then your reimbursement is much lower. And the Queens hospitals are typical in New York, are typical in that pattern, and they struggle financially. So those hospitals will see significantly higher reimbursement, those ones that are currently serving Medicaid populations. And some of the hospitals that have been serving primarily commercial patients will see some drop in income. I'm not sure if anyone's familiar with what's called global billing. This is another sort of aspect that'll probably be used. The details of financing are not in this. There's an outline of a rough outline of what the finance is supposed to be in the written bill, but the details have yet to be worked out. And the global billing is one of the details. In global billing, a hospital gets a fixed sum of money. They can just look at how much did you spend last year? And you get that amount of money divided into 12 equal payments spread out through the year. And then the hospital gets to decide, has to take care of all the business that comes across their doorstep and gets that money based on previous experience to provide that care. But the hospital gets to decide exactly how to use that in the hiring and everything. They don't have to waste money on the insurance business of trying to figure out who has what insurance. So the huge number of patients, of workers that are employed as billing clerks at hospitals will fall away almost to nothing. Now, what was
So there was the thing about how will the medical personnel get paid, which I think what you're saying is like if it's with the hospitals, they go, like it's like they're given like a sum.
The act, the people who wrote the act believe that prepaid kind of practice situations may be the most efficient way to pay. But they recognize that all doctors are not in those kinds of practices right now. And most of us, in fact, are used to working what's called fee for service. And so that the default payment system will be fee for service. The Act also specifies that specialty groups like primary care providers, like internal medicine or cardiologists are going to be able to negotiate with the healthcare system on prices, to make sure the prices are set at a level they can live with, each group can live with. So there'll be a significant amount of negotiation. And I know that from the Canadian experiences, it can be pretty noisy. Working that out is exactly where the payment levels will fall.
Right. So I don't want to spend too much more time on this. So like my doctor has a private practice. It's just her. And she employs one person at the desk and then 2 other nurses. So how would those particular people be paid, like the 2 nurses and her 1 secretary? And would she still pay them directly, or how would that work? She would still pay them directly?
She would pay, yes. In fact, and this is an important thing that you've really just sort of stumbled onto. is that we deliver healthcare in this country privately. The government doesn't pay for, except in the VA, for example, the government doesn't actually conduct healthcare. It doesn't hire doctors, except except in a few situations. Mostly, it's just like you described. Healthcare is delivered by private practices, and that's this act is meant to support that. That we're not changing that at all. It's publicly financed, but it's not. But it's still privately delivered healthcare. So when the doctor charges a particular thing for, say, $60 for an office visit, or whatever they happen to charge, the doctor has to allot out of that a certain amount that the doctor is going to keep as income for him or her to take home. Certain amount they're going to pay for rent, certain amount they're going to pay for their help. And for each patient that comes in, the doctor, that's what doctors do in all the private practices now. And that'll continue.
Gotcha. Thank you. All right, next. Would we have been able to better serve COVID-stricken patients if this plan had been in place? And if so, how? How would it have made a difference?
Well, the first thing is that particularly in the first half of 2020, before there was any decent federal support and decent sort of rules about saying, who was going to be responsible for testing, who was going to be responsible for hospital care. People were afraid to go to the doctor because of what was of the costs of the healthcare of going to the emergency room. We all heard horror stories of people getting bills of thousands of dollars for their COVID treatment. All that would have gone away. All that would have gone away if we'd had this in place during COVID. COVID would have been terrible, no question. But care would have been available as it was needed without ruining people financially.
Under the NYHA, the New York Health Act, what criteria will be used to assess medical necessity, and who makes that determination?
Well, medical necessity is something that is what you learn to recognize when you're in medical school or when you're in your physician assistant training program. You learn to say, when these conditions are present, this is what you need to do. That's what medical necessity is. And that's why we send people to school. That's why it takes several years of training to really be able to to take care of people properly. When a licensed provider says that something is medically necessary, it's medically necessary.
Okay. This is an interesting question. How would cost of state, town, and school district employee health care be affected by the New York Health Act? Would these fall?
Well, this is sort of an area of specialty of mine. Our local governments in New York State pay huge amounts of money to manage healthcare of employees, to provide health insurance for their employees. Public employees in New York State are pretty well taken care of. The insurance is pretty decent, but it takes a huge toll on our county, town, and school budgets. The answer is that millions of dollars are involved. In some recent studies for Saratoga County, they can save $40 million a year if under the New York Health Act in employee health benefits. The city of Saratoga Springs could save $6 million a year. the Saratoga schools, I think the number is 18 million a year that they could save. It's mind-boggling. My wife tells me, you shouldn't even be talking with people about that because it just sounds like a pie in the sky. No one will believe you. But the fact is that healthcare costs are for public employees is breaking our local governments. Mm-hmm. And if we don't do something about it, we're crazy because it's constantly driving up our taxes and curtailing other services that are critical. And why are we doing that to ourselves? It's such a waste. Excuse me. You touched a sensitive area.
Touched a little nerve there. So I just want to put this in because I had completely forgotten this until you started talking about this when I was doing my own research around the NYHA. You can actually go to the NYH campaign website, and they actually have a link, and I can't tell you exactly where it is, so you'd have to look for it, where they show the savings by county. And so if anyone's interested, you can do your research, and it actually shows the savings by county to the government offices, the city offices, the county offices. I'm not sure it includes school districts, but
counties are particularly dramatic because counties currently are responsible for about 13% of all Medicaid fees. Every county has. So Saratoga County pays about $24 million a year in Medicaid costs. That goes away under the New York Health Act. And that's one of the reasons that counties show such a incredibly dramatic drop in healthcare costs.
So will alternative therapies be covered with this?
If therapy, any therapy, at least, as a medical provider, I was taught that treatments that are medically necessary are treatments that are proven to be helpful. If you have strep and you don't take penicillin, something bad happens. And so it's medically necessary. And it's been established that it's, or at least it's agreed that it's a helpful treatment for the condition. For certain kinds of alternative therapies, let's say massage, if you want to consider that an alternative therapy, that's been covered in lots of places for a long time. Acupuncture, likewise, been covered as a medical therapy for a long time. Talk therapy, if you're being disabled by your anxiety or your depression, talk therapy is known to be helpful. For any new therapy that's not sort of currently covered by insurances now, which is what the Act is going to start out with, for new therapies that somebody would like to see included, people are going to have to offer that and show how it's beneficial. And my guess is that some alternative therapies where it's either difficult or is not possible to demonstrate that it makes a significant difference might not be included. But there may be a number of therapies that will be included because people will be able to put together the data that shows it does make a useful difference.
So it's going to be determined by research then, and by data that they can pull up and show that
it's going to constantly be reviewed.
Like massage therapy and other, therapies of that nature. Okay, well, that's important for me to know because I use those therapies.
Yeah.
So in Vermont, they established a single payer system, and it failed. So why would New York State think that they could do this and make it a success?
Okay, in Vermont, the legislature in Vermont passed a single payer bill. And when it went to the governor, the governor refused to sign it because he thought it was, he concluded that it was financially untenable. New York is a somewhat different animal. First thing, New York has a lot of wealthy people. It's a lot of wealth, and that will, and because this is because the act is progressively financed, the people who are wealthy will be contributing significantly to the maintenance of the act. Another thing is that Vermont didn't include Vermonters who were involved in out-of-state health plans. Mm-hmm. And the third thing is that they didn't sell it. It's fascinating that some of the research that was done, even with the plan as it was passed, would have reduced the cost for most Vermonters significantly, but it wasn't sold aggressively enough. It wasn't understood well enough. People were frightened that it was going to just cost too much. I'm hopeful that events like this and tonight and we've got to let people know exactly what we're selling here, what we're pushing, and how it can benefit them. 90% of New Yorkers are going to pay less. It should not be. It shouldn't be hard to understand why this is beneficial.
So that kind of segues into the next question, actually. How will the progressive tax that supports the NYHA impact individual incomes?
Okay, so let me tell you, a couple of guys, you know, when you're describing progressive tax, you show how the number's low when you at the start, and then the curve kind of goes up as you and the tax rates change as you go up. People, it's written, the details of the progressive taxation have not been finalized. However, it's written into the act that people with incomes less than $25,000 a year don't pay any tax at all. People on Medicare with incomes of less than $50,000 don't pay taxes, don't pay health tax at all. And then the tax starts going up from that point. It's not until you get to incomes of between $200,000 and $250,000 a year that the break-even point, and it depends on the 200 to 250, depends on whether you're self-employed or whether you're employed on somebody's payroll. If you're on payroll, the break is higher. If you're self-employed, the break is a little lower, around 200,000. But we're talking about $200,000, which is, you know what the median income is in New York? 51,000. So we're talking about the far largest part of the population having to pay less for better health care and complete medical coverage without other costs. And we're talking about a very small number of the most well-off New Yorkers, above $250,000 of income annually, paying somewhat higher rates of, and you know, it doesn't. I think that people with incomes in $400,000, $500,000 paying $100,000 for their health care might not be unreasonable. Those people are not going to feel the pain of that kind of sacrifice that anywhere near the way a person at the median income feels the sacrifice. Today, healthcare finance is very regressive. So if, let's say, a person's at that median income of $50,000, families pay about $25,000 a year in health, for health insurance, to get regular health insurance for family of four. There's about 20,000 in premiums and another number of thousand in out-of-pocket expenses. So somewhere, if you add that onto their median income, saying that's their, we're talking about a health care cost for them that's some fairly large, 25% or 30% of their economic resources. The way it's set up right now, the family of with an income of 400,000 who pays 25,000 for a family plan, the same as the median income person does. What percentage of his income is that? It's only a few percent. Is that crazy? That that's regressive. That is, we're expecting people at low incomes nowadays to pay a higher percentage of their income than the well-paid person does. That's crazy. So I hope I answered the question.
Yeah, I was just going to say, again, if you go to the NYHcampaign.org, they have a very simplified graph of monthly deductions. And it shows that the employee still pays into the, the cost.
Yep.
And so say like for $50,000 a year, the employee would pay like $38 a month and the employer would pay $150 a month. And then if you're self-employed, it's $188 a month. So that's just, and then they have figures like that you can look at to see how that would affect you. And that's probably a little oversimplified in the chart, but it might give people an idea, I know when I looked at it and I figured it out, now I'm retired, but according to this, my monthly cost would be $666, which is definitely less than what I'm having to pay now as an individual that's part of no plan. And so anyway, and I have a huge deductible this year.
Yeah, and
huge. So anyway, okay. Will this bill drive providers, particularly therapists, to operate outside of insurance / the state plan?
Well, I don't know the answer to that. If the question is, will providers of one sort or another, therapists or whatever, or doctors, be allowed to do any kind of cash business on this outside of the plan? And I don't know the answer to that. What I do know is that the act is very clear that if something is covered, if some kind of service is covered by the plan and you're a provider, you're not allowed to accept any other reimbursement for that service you're other than what the plan pays you, and you're not allowed to deal with any other insurance company for that kind of service.
They can't double dip, kind of.
You can't go beyond what the plan provides. That's correct. Now, whether people could function entirely outside the plan on a cash basis, I do not know. But no other insurances are going to be allowed in the state. But whether somebody could just do a cash business, I do not know. And cash business is not really practical because, well, most of us have gotten the insurance through associated with work, and that's still going to be the case. But if you lose your job, the insurance doesn't go away.
Right.
It doesn't change at all. And there's no copay and deductible. There's no deductible at all that Maxine just referred to.
And it also, just to add, because this was one of my concerns, it also follows you out of state as well, which has been a question that has come up. So the answer is yes, it does follow you out of state. So the next here is, will this also reduce insurance related costs for employers? And sorry if you've already covered this, didn't exactly cover the employer cost. So I guess what they're wondering is will it reduce the cost that employers pay now to insure? Will this reduce their cost?
In most situations, it does. For the highest paid employees, so if you were running a car repair shop and most of your workers were folks who were around median income kind of thing, there would be a drastic reduction in the healthcare costs for the business. If you were a Manhattan law office, and the amount of money you'd be paying out for your higher paid employees would be significantly higher under the Act, because many of those highly paid employees are going to fall under the higher rates of taxation. Now, the secretaries in that office, you're going to be paying way less for them than you would have paid previously. But for the highest paid employees, the employer cost would probably be higher.
Okay. So just one last question, and then I think that we'll wrap it up we have a little video that we're going to show, about 5 minutes. It's totally worth you staying on to watch. Let me see. Oh, what will the New York State residency requirement be?
Let's see. Well, the New York State residency requirement, you can look that up online pretty easily. You can prove you have to be living in New York State. I think it's 184 days a year or something like that. You have to be physically in the state. You don't have to be at your residence. But there's a very, look, this is a good one just to Google. What's the New York State residency? I did that yesterday. And I don't have in mind all the little details. You can prove your residency by providing certain kind of documents. Things like your driver's license and your electricity bill and a deed to your house and various things like that. So the residency is just very, very straightforward. All residents, if you can prove yourself to be a resident, you're covered, included in the plan. If you have worked full time in New York but happen to reside in New Jersey, you're still covered. You can still be covered by this remarkably complete insurance plan.
Cool. Okay, so I just want to put in a little bit of a plug here that if you feel like this is something that you would support, that you think it would be good for the state, and you really feel that, yes, it's not going to rectify all disparities in society, but that it would help bring a certain level of justice to people living in poverty, to the immigrant population, to yourself, to people of color, and you could support this, then definitely before March 29th, actually, send a memo of support to your legislators, your state senator, your assembly person, and let them know that you support that. And I'm sure that Reese has put those numbers in the bill numbers in the chat for you. It's A6058 and S5474. So, and with that, George, do you want to introduce what we're going to do next? Do you have something else you want to say?
I just wanted to say this. Were you going to talk at all about Camara Jones?
Oh, I had thought that you were maybe going to do that but if you want to just.
I wanted to, that's what I just wanted to,
Yeah,
before
you go ahead.
see the video. This little video is just 5 minutes. It sort of crystallized some of the issues that we've been talking through here tonight. Camara Jones is a just completely remarkable woman who was a past president of the American Public Health Association. And she is, as a public speaker, she's a knockout. She does TED Talks and things like that. And this little video she has called it's a cliff analogy that she talks about, which relates to health. So please pay attention to this. This is a really good one.
So I just want to thank everyone again for attending tonight. And one of the really nice things I find about that video, and I've watched it several times at this point, is that, to me anyway, it makes me feel like, you know what, this is actually solvable. And I know that we've been at trying to bring a better world into being for ever, and in this country for a long time, but that we really aren't out of control completely in what happens, that we really can make a difference. And if we unify our voices and we speak out and talk to our legislators, talk to our neighbors, that we can bring greater justice in healthcare and otherwise. Anything else you want to say? And I need to also thank Caffe, Lena, for giving us this platform. I meant to do that right at the beginning. Reese has been great, and Carolyn and Sarah. So thank you all very much. So with that, have a good evening and see you next time.